Welcome to the Healthy Matters Podcast with Dr. David Hilden, primary care physician and acute care hospitalist at Hennepin Healthcare in downtown Minneapolis, where we cover the latest in health, healthcare, and what matters to you. And now, here's our host, Dr. David Hilden.
Hey, everybody, and welcome to episode 14 of the Healthy Matters Podcast. I'm your host, Dr. David Hilden, and thank you for tuning in today. So let me ask you this. Have you ever heard someone mention Crohn's disease and thought, wait, is that stomach thing, or is that IBS? Is it IBD? Well, don't worry, you're not alone. Today, we're tackling what Crohn's disease is, how it affects people, what causes it, and what treatments look like in real life. To help us make sense of it, I am joined by Dr. Jason Ekman. He is a gastroenterologist at Hennepin Healthcare right here in downtown Minneapolis, and he specializes in diagnosing and treating conditions like this one. And he's helped countless patients navigate life with Crohn's disease. So, Jason, welcome to the podcast.
Thank you very much for having me.
Great to have you here. So start with the basics, if you would. In the most basic terms, what is Crohn's disease?
Yeah, so at its most basic, Crohn disease is a condition where the body attacks the lining of the intestines, leading to inflammation.
So why is that a problem?
Well, it's a problem because inflammation leads to a lot of really uncomfortable symptoms that can really affect your quality of life.
Okay, so inflammation in your bowel, is Crohn's disease inflammatory bowel disease? Is it the same thing?
Crohn's disease is a type of inflammatory bowel disease. Ulcerative colitis would be the other main camp.
Okay, so we're not going to talk tons about ulcerative colitis today, but can you summarize how they're different?
Sure. So ulcerative colitis, by definition, is inflammation of the colon. So colitis means inflamed colon. Crohn disease can involve the colon, but it can also involve anywhere else in the gastrointestinal system, anywhere from the mouth to the anus.
Okay, so we're going to be talking about a specific kind of inflammatory bowel disease, Crohn's disease, today. Paint a picture for us. If I were to visualize, what does inflammation of the bowel wall look like? And why is that a problem?
Sure. So just like we have skin on the outside of our body, and that skin can be inflamed and have rashes and bruises and cuts, so too the inside of our intestines has a skin, if you will, as well, called mucosa. And so when that skin gets inflamed in the inside of your intestines, it leads to the pain and the discomfort and everything else we'll talk about with Crohn disease.
And there's lots of causes of that, right? Of inflammation, not of Crohn's. But I mean,
absolutely,
you can have lots of reasons your intestinal wall can be inflamed.
Sure, anywhere from infections to foods you eat to conditions like inflammatory bowel disease.
Okay, so let's talk about causes. Who gets Crohn's disease and why?
So anybody can get Crohn disease, but the most common people we see that in is patients aged about 15 to 30 years old.
Oh, that's young.
It is young, yeah. And so we actually bridge with our colleagues in the pediatric population as well. But again, anybody can get it. And we also see a second peak later in life, sort of between the ages of 50 and 80 as well, for reasons that we don't quite fully understand.
Do we know why people get it?
So that's a complicated question. It's not just one specific thing. So there's definitely a genetic component. We do see that people with a family history, especially in parents or siblings, are more likely to get Crohn disease than people without that. But that being said, people without a family history can certainly get Crohn disease as well. And then there's also likely an environmental component, if you will. So things that we're exposed to, like certain infections potentially, ingestions, other sorts of illnesses can lead to Crohn disease.
What about diet? Does that affect it? Doesn't cause it.
It doesn't cause it. So diet may play a role. We have yet to identify a specific food or a specific food group that is the cause, but certainly there's a possibility that something that we ingest helps to precipitate the inflammation.
So how common is it?
It is something we see pretty frequently in our clinic. So estimates I've seen recently estimate between half to a million people in the United States have Crohn disease. Upwards of 7 or 8 million people across the globe have inflammatory bowel disease, which again is that combination of Crohn disease and ulcerative colitis, but it's definitely out there.
So that's a lot.
A lot of people.
Yeah, this isn't, I wouldn't call rare. It's maybe not, super duper common. It's not like high blood pressure, but this is not a rare disorder. You see it all the time. I see it in my clinic in a primary care practice.
Yeah.
And listeners, what I do when I do see it is I send it to guys like Dr. Ekman. Before I move on to what does it look like, signs and symptoms, why the word Crohn's disease? And okay, listeners, nobody can spell it either. So if you don't know how to spell it, I gotcha. It's Crohn. Crohn. It must be some guy.
It is exactly that. Some guy who first described this sort of constellation of inflammation throughout the intestines. And it actually is Crohn disease.
Oh, it's Crohn. I've been saying Crohn's the whole time.
And you'll hear me say Crohn's disease as well. But it really, if you look in the literature, it is CROHN disease.
No apostrophe S. Okay.
Yeah.
Well, okay. I've been doing this for 25 years, and I think I've been getting that wrong.
It's not just his disease; it's all of our disease.
It's all of our disease. It's just like Lyme disease. It's Lyme. It's not Lyme's, and so
Correct.
It's the same as the true for Crohn, and it is CROHN. And if there's anything in a medical literature or medical document in a chart that's misspelled more often than Crohn's disease, I don't know what it is. Okay. So now that we've tackled that, before we move on from that, we're always naming things after usually some guy from 50 years ago, 100 years ago, 150 years ago. So we're kind of getting away from that in medical science. So I wonder what it'll be called in the future. But right now, it's still Crohn disease. Okay, symptoms. When patients come to see you, what are they telling you they're experiencing?
So most commonly, we see patients come in with abdominal pain and long-standing diarrhea, so lasting several weeks. The diarrhea is frequently bloody, but it's not always. Weight loss, nausea, vomiting, fever, often seen as well. And to complicate things even further, people have symptoms outside of their GI system. So skin rashes, eye problems, joint pain can all be associated with Crohn disease as well.
So those could be caused by lots of things.
That's what makes it so challenging to diagnose.
How often do you see what sounded like more serious symptoms, fever, bloody diarrhea? Because I think there's a lot of listeners right now who are going, well, yeah, I got loose stools. I have diarrhea all the time. But probably fewer are saying, yeah, and I'm also got a fever and I got weight loss and I got blood in my stool. How often do you see those?
So they're probably the more commonly seen in patients with Crohn disease. Patients who have loose stools or mild abdominal pain for other reasons could have Crohn disease, but more likely other conditions leading to that. But I'd say the majority of patients with Crohn disease have at least one or more of those more severe symptoms.
So when should somebody seek attention, particularly from a specialist like you? Because I'm just trying to imagine people listening to this and how many people are saying, yeah, I have loose stools. I do. I have them almost all the time. When should they come see somebody?
Well, if you're having loose stools almost all the time, you should probably come see us. And again, it may be Crohn, it may be something different, but certainly worth talking to us. We've all experienced short-lived symptoms, nausea, vomiting, abdominal pain, diarrhea, and 9 times out of 10, that's a GI bug, food poisoning, something like that. Lasts for a few days, passes on its own. But, if these symptoms start to last 2, 3, 4 more weeks, maybe you start losing weight, you start to see that blood in your stool, at that point, you should start thinking more about a chronic disease like Crohn disease. To be honest, severe complications can develop from ignoring these symptoms. And so it's really important to get on top of them early.
I was going to ask you about that. Is there a benefit to finding out about it earlier in the course?
Absolutely. So as that inflammation progresses throughout the gastrointestinal system, we see things like fistulas, which are abnormal connections between loops of bowel. We see strictures, which is essentially scar tissue leading to narrowing of the intestines. We can see perforations or holes in the intestine, and that longstanding inflammation can even lead to colon cancer in some situations. So early is better. Some
fairly unsavory things that can happen later in the disease. So how do you diagnose Crohn disease?
So it's really a combination of a lot of things. First we'll see you in clinic with the symptoms that we've talked about. We'll often get lab tests on that day. We'll do a physical examination as well, and then see if we can get a sense for where that abdominal pain might be coming from. The next step is typically a scope. So a colonoscopy, maybe an upper endoscopy, depending on your symptoms. This allows us to look directly on the inside of your intestines and see what's involved and even take samples to confirm the diagnosis. And we'll often obtain an imaging study as well, something like a CT scan or an MRI, to help get an idea both of where the Crohn disease is involving your system as well as any complications that we've talked about.
So you're the guy at the control end of that colonoscopy. You've got the controls in your hand. You've got the machine. You got your video monitor. All the rest of us are at the business end. We're at the other end of the colonoscopy. Could you give us the insider's take on what does Crohn disease look like when you're in there versus what a normal colon looks like? What are you looking for?
Yeah, so again, going back to that analogy that I talked about earlier with the rash on your skin, normal looking skin is quite smooth and healthy appearing. Same with the inside of your intestines. We see a very smooth, shiny, health appearing mucosa. When patients have Crohn disease, we see a lot of redness, irritation. We can see very deep ulcers. And all of these things are a strong sign that something wrong is going on.
So you can visualize it and see this doesn't look normal.
Can definitely tell it doesn't look normal. I can't guarantee 100% just looking at it that it's Crohn disease, but I can certainly get to the point where I can take samples and confirm the diagnosis.
So when you're taking a sample or a biopsy of someone's intestinal wall, how do you do that? Because I've talked to a lot of people saying he's going to take a chunk out of my, it's not a chunk, but how do you do that?
Yeah, so we have what's called a working channel in our camera. So it's a really long, flexible tube that we use to visualize inside the intestine.
Long being the key word.
Yep, long and soft. It's
okay, it's soft and flexible.
And we can put this very, very small instrument called a forceps, which is essentially a microscopic tweezer that'll take like a millimeter sample out of the intestines. You can't feel it. You won't notice that it's gone, but it gives us enough information to get the diagnosis.
And then you send you pull it through your scope back out and you put it in a jar or whatever, and you send it off to a lab, and that's how you can make the definitive diagnosis.
Exactly. We ask for help from our friends in the pathology lab to tell us what we saw.
Okay, so that's the diagnosis. We're talking to Dr. Jason Ekman. He is a gastroenterologist, and we're diving into Crohn disease. And right now, we're going to take a short break now that we have the foundation of what Crohn disease really is. When we come back, we're going to discuss what it's like to live with Crohn disease and what treatments are available. And I'm here to tell you there's a lot more treatments than there used to be. I'm going to ask Jason what the future looks like for Crohn disease and what people need to know who are living with Crohn disease. So stick around. We'll be right back.
When Hennepin Healthcare says, "We're here for life," they mean here for you, your life, and all that it brings. Hennepin Healthcare as a hospital, HCMC, a network of clinics in the metro area, and an integrative health clinic in downtown Minneapolis. They provide all of the primary and specialty care you'd expect to find, as well as services like acupuncture and chiropractic care. Learn more at hennepinhealthcare.org. Hennepin Healthcare is here for you and here for life.
And we're back talking with Dr. Jason Ekman about Crohn disease, one of the inflammatory bowel diseases. He is a gastroenterologist at Hennepin Healthcare. Dr. Ekman, let's talk a little bit about the impacts on people's daily life. Can you share with us what you hear from patients about how their Crohn disease can affect their daily life?
Yeah, it's a disease that really has wide-ranging effects on all facets of life. It can be difficult to go to work, to school, to socialize, raise a family, just deal with basic life with a lot of the symptoms we've talked about. For example, eating out or even eating in at home can be challenging when you have nausea, when you're worried that next meal is going to send you a run into the bathroom. So patients are constantly vigilant of where the nearest bathroom is, how quickly they can get there, and a lot of logistical challenges like that. So both these physical and emotional symptoms really wear you down with time.
Is there much pain associated with it?
Absolutely. Again, physical and emotional, right? But, abdominal pain, that inflammation really can make your stomach hurt quite a bit.
So what advice do you give people? We're going to get into some of the treatments to actually relieve these symptoms, but it's not curable. Really?
That's correct. It is not curable from the sense that
traditional sense,
cancer can be cured in certain circumstances. It's a chronic disease. You live with it the rest of your life. But like you said, we'll get more into medications and treatment options, but we do have good options there.
Yeah, there's some really good options now that can be actually, my patients have said, kind of life-changing for them. What advice do you give people, though, while you're getting them into some treatments with the hope for some better results in the future? What kind of what advice do you tell people?
I think it's important to be pragmatic. So if you're living with Crohn disease, taking that trip up to the Boundary Waters for a week or an international flight may not be, the best decision if your symptoms aren't under great control. But once you get on the right medications, you stay on the right medications, most patients can lead essentially pretty normal lives, maybe working around their medication schedule, but otherwise they do quite well. So I really stress the importance of getting on and staying on the right medications.
So you mentioned earlier there are some long-term potential complications, particularly with untreated Crohn disease, and some of those were fairly significant. Does the disease, if it progresses, lead to a shorter life expectancy? In other words, is it a life-threatening illness?
It can be a life-threatening illness, and certainly we see patients in the hospital with very severe symptoms that are in a life-threatening situation. There are patients with very severe disease that probably have a slight decrease in their life expectancy, but most patients, again, when they get on the right medications and stay on those medications, they live very normal lives that shouldn't really significantly decrease their life expectancy.
So that's hopeful. What about some of the other complications you talked about in our first half of the show? You mentioned things like fistulas and increased colon cancer risk. Could you say a little bit more about that? I'm going to imagine that lots of people don't really know what a fistula is.
Yeah, so a fistula is basically develops when you have a lot of inflammation and it hooks up or connects loops of bowel that shouldn't be connected and bypasses large amounts of the intestine, which can lead to problems with absorption of nutrients, hence that weight loss we talked about and some of the other symptoms.
And fistulas can be fixed, or is that just like something you live with?
No, fistulas can be fixed. Sometimes just treating with the right medications and reducing that inflammation allows those to close up, but sometimes surgery is needed as well.
Okay, let's get into some of the treatments. So starting out with immediate treatments for symptom relief, and then let's get a little bit more into the long-term medications that are available now for treating it.
Sure. That's a great distinction to make. We use things called steroids, which are different than maybe the steroids you think about for bodybuilding, but these are very potent anti-inflammatory medications that act very quickly and are very effective for almost all patients at really reducing that inflammation and therefore the symptoms right away.
Yeah, so these are corticosteroids. They are powerful anti-inflammatories. I've talked about steroids a lot on the show, and I'm never referring to the bodybuilder type listeners. We're always talking about the
so they're aware. Yeah.
Well, I don't know if they're aware. I always say it. We're not talking about what you might think. But I have said on the show, steroids, they kind of cure what ails you because they're an anti-inflammatory and they sort of calm everything down regardless of where the inflammation is. So does that help in people's symptoms when they take prednisone or something similar?
Yeah, exactly. Patients within a few days to a week feel typically much, much better. The downsides, which you may have talked about on the show previously as well.
Well, tell us what they are, because I haven't lately.
Sure. Yeah. So there's a lot of side effects that can arise from taking long-term steroids, things like diabetes, things like poor sleep, weight gain, and immunosuppression, meaning an increased risk of infection.
Yeah, you really don't want to be on steroids if you can help it.
That's true.
For your whole life. But that's kind of what we had for the longest time.
Right. Yeah.
And then we had some other things. You gave enemas and this, that, and the other thing. What are some of the other symptomatic relief things people can take?
From a symptom standpoint, we can take pain medications like Tylenol, which can help to some degree. We can take anti-diarrhea medications like loperamide or Imodium. But those are really sort of a Band-Aid approach. You're helping with the symptoms, but you're not directly affecting the underlying disease.
Right. It doesn't get at the causes at all. Okay, so let's talk about what's come out in the last 5, 10, 15 years. And there's now what I would probably venture to say is the mainstay of treatment of Crohn disease. The biologics, what I refer to as biologics. Could you talk about those?
Sure. I think, maybe before we move on to the biologics, we had and still have a class of medications called immunomodulators, which were very common for decades and are still used to some degree. These decrease inflammation very effectively and can be used longer term, but they tend to have a bit more side effects and need more frequent monitoring, and that's where the advent of these biologic medications has really been helpful.
Yeah, thanks for that reminder, because I skipped over a whole class of medicines there. These immune modulators, what are some of those?
So azathioprine is probably the most common one you'll hear about. There's one called 6-mercaptopurine, another one called methotrexate. All are quite effective medications for a lot of patients, but again, with some of the long-term side effects, I think are moving away from those and more towards the biologics.
If your physician does recommend azathioprine or 6-MP, those are still accepted treatments?
Absolutely. I still use them. And sometimes I use them in combination with others, sometimes on their own, but they are still very acceptable treatments.
And those have been around a long time.
They have been for a lot of different diseases.
Yeah, people might be familiar with those from a variety of things. So the biologics that I alluded to earlier, these are the most modern, for lack of a better word, treatments. Talk to us about those, yeah.
Absolutely. These really have become the mainstay of treatment over the past couple decades, probably. And these target the inflammatory cascade, we call it. So basically the process of inflammation within the body. They're very effective. They're better tolerated than some of the other medications we've talked about. The downside to a lot of them is that they're often given through the vein, so intravenously or subcutaneously, meaning under the skin, which can be a bit of a hassle for some people.
Yeah,
but
you're not just taking a daily pill.
Correct. But they are so effective and they work so well that patients tend to be okay with dealing with that inconvenience.
How often do you have to do that? Or I know it varies.
It does vary.
But it's not every day.
It's not every day. So usually it's anywhere between every 2 weeks to every 8 weeks.
There's another downside to the biologics is that you can't pronounce any of them.
That's true. But thankfully, the pharmaceutical companies have come up with catchy names that we can say easily.
I know. And I will tell listeners, I have an issue with advertising of medications. But if you're watching TV and you see some of these medications with all these bizarre names, if you look kind of closely at the generic name that they sometimes put on the screen, it usually ends in an AB or an IB. There are too many syllables and there's too many consonants in there, but those are the medications we're talking about.
Exactly.
And they're asking you to go ask your doctor if such and such is right for you. That's kind of what the biologics are. But that cynical side, put that aside, they're highly effective.
They're very effective. And sometimes we try one and maybe it doesn't work, but you can almost always find a different one that works in a different way that'll work for a patient.
What types of side effects might people get? You said they're fairly well tolerated, probably a lot fewer side effects than, say, prednisone and the steroids.
Definitely. So the most common are mild infusion or injection reactions. More serious side effects would be infection. It does suppress the immune system, and so you're at a slightly increased risk for things like, colds or other mild infections like that. There are some much lower risk of things like developing skin cancer or lymphoma, but those are incredibly rare and something we can keep an eye out for before they hit.
So these more advanced medications, are they treating symptoms or are they actually doing anything to the underlying disease process?
So they're doing both. By addressing the underlying inflammation and disease process, patients will also feel better.
Does it affect the long-term course of the disease, or don't we know that? So in other words, are you going to be a different person 20 or 30 years down the road because you took these now?
Probably. So as I think I alluded to earlier, if you don't treat disease early on, the disease can progress. That inflammation leads to all these complications we talked about. So by getting on that medication early, and again, I'll stress it, staying on that medication, even if you're feeling well, that prevents flare-ups of your disease, inflammation coming back, and can hopefully reduce the likelihood that these complications arise.
You alluded to surgery earlier, and patients do ask me that a lot. Is there a surgery for this? What do you say to that?
A lot of patients end up needing surgery for Crohn disease.
What do they do?
So what they typically do in these situations, we do surgery for one of two reasons. One is we can't find a medication that is effectively treating the inflammation. And in those circumstances, we can try to remove that area of the intestines that are inflamed. The challenge there, though, is that Crohn disease can affect anywhere within the intestine. So we take that area out. It's a little bit like whack-a-mole. It can pop up again somewhere else in the bowel.
Right. You said mouth to anus.
Right.
How do you know what to take out?
You can't take it all.
Yeah, you can't take all that out.
Yeah. So you take out the area that you know is causing the problem now, and then you hope that you can get a patient on a medication and prevent it from flaring up elsewhere. The other reason we would do surgery is developing any of those complications we talked about earlier. So the fistulas, the strictures, the perforations, we do surgery then to remove those areas that are problematic.
I do want to go back briefly to ulcerative colitis, the other big inflammatory bowel disease, because isn't surgery a little more straightforward in that case?
It is. We often approach it in a similar way, meaning if there's been a complication or if we can't get your symptoms under control with medications, we pursue surgery. But as I talked about earlier with colitis, meaning colon, by definition, ulcerative colitis only affects the colon. So
you know where it is a little bit better.
We can essentially cure ulcerative colitis by fully removing the colon with surgery, if need be.
So back to Crohn disease, is there a certain place in your GI tract from mouth to anus, the whole thing? Is there a place where it's most common?
It's most commonly seen at the very end of the small intestine, which is called the ileum, and then the very first part of the colon, which is called the cecum. And so ileocecal Crohn's is the most common way we see it. But
right at the farthest end of what you can see with a colonoscope, right?
Correct.
So you can see it in that place.
Yeah, probably 3/4 or more of the time we can find Crohn's in that area. And then elsewhere in the colon or the small intestine is a little bit harder to find there.
How does one find it in the 20-foot-long small intestine? You can't put a scope in there.
That is true, thankfully, for my job and for patients.
Can you imagine
that?
The 5-foot-long
Yeah.
scope they use for the colonoscopy is long enough.
Yeah, long, but not that long. So what we do is either use imaging, so the CT scans, the MRIs that I talked about earlier, or we have something called video capsule endoscopy, or colloquial, the pill cam, which is essentially a large pill that people swallow with a camera in it that takes pictures every couple seconds and traverses the whole length of the intestines and can give us some good pictures of what's going on.
People ask me a lot about the camera that you swallow. That's what you're talking about,
Pill
right?
cam, exactly.
Yeah. And that must be a heck of a deal to look at those pictures. You got hundreds, thousands of pictures of the inside of someone's intestines. They must all start to kind of look alike.
That's not the most exciting part of our job.
Do you read those?
Thankfully, I do not yet, but I'm sure it's coming down the pipeline for me.
I'll bet you guys fight over who gets to look at
Yeah.
thousands of pictures of the inside of someone's intestines. Not exactly as good as looking at someone's vacation photos, eh?
Right.
Okay, I would like to, before I let you go, talk a little bit about the future. What might be down the road that you're aware of, either in research, new medications? What does the future look like for people living with Crohn disease?
Yeah, so, as you alluded to, not too long ago, we only had a few medications available to us. And now it seems like every few months or every year we have a new medication. Every few years we have, a new class of medications that we can use to help treat patients, which is really exciting. It's a very active area of research. And I think the genetic component as well is probably going to come into play quite a bit more, where we're able to identify certain medications that will be more effective for certain people depending on their genetic makeup.
So a little less trial and error. Hey, try this, see if it works, and then try something else, see if it works. I'm being a little flippant about it, but sometimes we have to try medicine, see if it works for you.
Exactly. You never know who's going to respond to which medication.
Right. And wouldn't that be great if we knew ahead of time, hey, the genetic type that you have, this is the medication that might work best. That's exciting. That's actually quite encouraging.
Mm-hmm.
What other resources are available for people living with inflammatory bowel disease?
I think a great resource is the Crohn's and Colitis Foundation. People may already be aware of that, but they're probably the largest organization of both experts and patients who are involved in Crohn's disease and ulcerative colitis. There are a lot of great resources on their website, ranging from just good information about the disease, as well as community resources, get-togethers, and crowdsourcing of different techniques and approaches to dealing with life with inflammatory bowel disease.
And listeners, we'll put a link to those in our show notes, so be sure to check those out. Dr. Jason Ekman, what would you leave listeners? If you had a bit of advice to leave about this topic, what would that be?
So I think one important thing is really listening to your body and listening to your symptoms. As we've talked about, I think several times already, we don't want to leave Crohn's disease undiagnosed and untreated for a long time. The other thing is Crohn is a scary disease, and you hear people like me today saying, well, we don't fully understand it, and that can sound very scary to somebody diagnosed with Crohn disease. But I just really want to reiterate that we have great medications, and so if you come to see us in clinic and we make this diagnosis, we really can help you.
Thank you for that. I personally have sent people to the gastroenterologist at Hennepin Healthcare, including Dr. Ekman, with some kind of scary symptoms. They had diarrhea for ages. They're losing weight. They're in pain. And due to the expert treatments available and the expertise that's available, their lives were actually changed for the better. There's a lot of hope on the future and the treatments available for you if you're living with Crohn disease. And this is a friendly reminder. If you're having symptoms and you don't know what they are, please do seek help. Go to your primary care physician or other clinician. Go to a gastroenterologist. There is help available for you. Jason, thanks for being on the show today.
Thanks for having me.
It's been a great conversation about Crohn disease. And listeners, I hope you picked up some information that's useful to you. And I want to thank you for joining us for the podcast. And I hope you'll join us in 2 weeks' time when we drop another episode. And in the meantime, be healthy and be well.
Thanks for listening to the Healthy Matters podcast with Dr. David Hilden. To find out more about the Healthy Matters podcast or browse the archive, visit healthymatters.org. Got a question or a comment for the show? Email us at healthymatters@hcmed.org or call 612-873-TALK. There's also a link in the show notes. The Healthy Matters podcast is made possible by Hennepin Healthcare in Minneapolis, Minnesota, and engineered and produced by John Lucas at Highball. Executive producers are Jonathan Comito and Christine Hill. Please remember, we can only give general medical advice during this program, and every case is unique. We urge you to consult with your physician if you have a more serious or pressing health concern. Until next time, be healthy and be well.